on this computer.
Good morning, afternoon, or evening, depending on where you are tuning in from. My name is Marni, and I want to welcome you to our session on collaborative relationships between the physician and patient in treating pain. We're excited to have you joining us on Medical Day of 24 Hours of Rare, and I'm even more excited to have you here with us as we discuss the complex relationship between patients and physicians, but a relationship that I view as an incredibly important one. I'm joined today by Dr. Frank Ocasio, who is a pain management specialist. He's also my personal physician. Not personal, but he is my treating physician. And I'm very excited to have him here and have the audience have the opportunity to hear the different perspective between the patient, myself, and the physician, Dr. Ocasio, on many different issues, ranging from communication styles to, of course, controversial topics in pain management. I want to remind everyone that we're going to be discussing sensitive topics, and while Dr. Ocasio and I might not always agree on everything, the important thing is that we respect each other and we have an open line of communication and are able to address where we don't agree in a calm, collected manner. Additionally, I want to remind everyone that this is not supposed to take the place of your own medical advice. We aren't going to get into detail on medical procedures, but we might mention things that you have not heard before. We absolutely say, go ahead, talk to your doctor about it, but we're not endorsing anything because, of course, we don't know your medical circumstances. So with that, I'm going to introduce myself. My name is Marni Cartelli. I'm an advocate, but first and foremost, I am a patient. I have a rare disease that's called complex regional pain syndrome, which was triggered by an accident at work. The condition itself is believed to be a neuroinflammatory disease, and I kind of liken it to your nerves not understanding the fact that they're supposed to turn off after you've healed from an injury. So what happens is it gets the pain signals go on this feedback loop in your brain where they're constantly telling you you're in pain, you're in pain, you're in pain, even when you might not be anymore because you've healed. So once it's on that feedback loop, it's very hard to break the cycle. It's the very short crux of what's going on with me. And now I'm going to have the absolute pleasure of introducing you to Dr. Ocasio. So Dr. Ocasio, would you mind just introducing yourself to the group that we have today?
Sure. Excuse me. So I'm an interventional pain doctor. I had my base training as an anesthesiologist, and then I got specialized training in pain management with understanding both the medication side of it as well as the procedural side of it, and how to improve people's quality of life when they're suffering from chronic pain. I've been in practice for over 10 years now, and I have an office-based practice in Huntington, Long Island, as well as having some affiliations throughout the region, and I practice as an anesthesiologist in multiple hospitals throughout the region as well.
Great, thank you. And I noticed that you said you're an interventional pain management doctor. So I assume that means there's different types of pain management physicians. Would you mind explaining how that's broken down a bit?
Sure. So to be a pain management specialist or to be board certified in pain management, it takes an extra year of training in addition to a base training. Most board certified pain doctors will be either anesthesia based, meaning they spent 4 years and did an anesthesia residency and then did 1 extra year of specialized fellowship training in pain management, or they might have done physical medicine and rehabilitation as their residency. So they got specialized training in that and then got one more year to do pain management. There are other pathways, which could be neurology or psychiatry, so and some others, but the predominant ones tend to be either anesthesia or physical medicine or rehabilitation. And essentially what that means is that we spend a dedicated year trying to learn about some of the more typical pain syndromes, such as herniated discs, spinal stenosis, some injuries where you have maybe a car accident or some sort of traumatic injury that maybe is taking a little bit longer to heal, and then that all kind of blends into some of the more chronic things where now you have some rare diseases such as chronic or complex regional pain syndrome, which can be more or less a lifelong pain syndrome that we try to treat. So there's a broad spectrum of diseases and pain syndromes that we learn how to manage from both a medical standpoint as well as from a procedural standpoint.
Now, as a patient, should it matter to me whether I know if I'm going to see an interventional pain management specialist or a general pain management doctor before I'm going to see them?
I would say that that depends. It kind of depends on what you're looking to get out of the experience. So if you're someone who says, I never want to touch a medication at all, and I just would like to see if there's a way to take my pain down to a controllable level, then I think an interventional pain doctor is perfect. If you're someone who is not interested in undergoing a procedure or potentially just wants someone to help them manage some complex medications, then an interventional doctor may be able to help. But I would say that that would probably be more someone who's doing some of the medical management, and that would be more of their specialization.
Great, thank you. So I'm a patient, not me, but we're making a fake patient up here. And I'm going to see a new pain management doctor for the very first time. A lot of times that first visit can make or break a relationship. So how do I, in your opinion, prepare best? You know, I'm guilty of this myself too. You know, the first time you go to a doctor, I have a stack of medical reports that is this thick and has everything from the last 10 years. And especially with rare disease patients, we have long histories, perhaps a lot of misdiagnoses, not, never been diagnosed. So we have 20 different tests that were run in different years. What is the best resources to provide you at that initial visit to help you understand where we're coming from as a new patient?
I think that it's good to have a large folder, because at least you have a record of everything that's been done to you. I think that's good to have. I think that it's good to refer back to, especially if you've seen multiple different practitioners or you've been in different hospital systems, because those networks don't always communicate. So having that record might be nice, especially if the history is much more complex. Do I always have time to read the large folder? Probably not. Just imagine that every patient came into the office like that, and I'm just have maybe 30 minutes for a follow-up appointment, 1 hour for a new consult where I'm doing an examination and all these other things. And so that doesn't mean that I won't refer back to it. In the same way, you use a dictionary. You're not going to read the dictionary from front to back. You may go back and say, how do I spell this? What's the definition of that and that? So it's good to refer back to. And then I think that I've seen multiple patients who have very complex histories. Some bring the folder, some just give you the Cliff's Notes. And in any relationship, I think it's important to understand the signs that someone's giving you. If they bring the big folder, that means they want you to see what they've experienced and what they've gone through, and so hear their story. Obviously within as much time as you're allotted. But I think seeing that clue and trying to understand, they've been through a lot, and they want to make sure that you fully understand their story before you then go off on coming up with a conclusion as to how to best manage that patient. But I think overall, try to understand that you're meeting someone for the first time, whatever physician that you're going to see. And you're going to develop a relationship. Try to the best that you can, not have too many expectations about what this person is going to do for you. I've had people come in and say, I want X, Y, and Z. and I may find that that is not the best treatment plan. And then now I have to steer them off of something which, a patient might be very convinced about, either because a friend told them that they had something done or they read about something. So as much as you can have an open mind at the first interaction, I think that's very helpful.
Okay, now feeding off of that, how do you handle both in a new relationship and a more established relationship? Because I imagine it's two different ways of handling when somebody has a preconceived notion of something they want to try or something they've researched. Because especially in the rare disease community, we have out, Google Scholar, we have all, the journal articles. If we have we're looking, especially if we're diagnosed with something that suddenly is labeled incurable. We're like, oh, well, let's find out if it's not able to be cured. Let's at least find a way that we can treat this. And we're looking for the ways to do that. So we might have different ideas than, let's say, you're used to, or any physician. I don't mean to put you on the spot like that. But so how do you advise patients to approach a situation like that? And how do you respond when it is something that you disagree with?
Okay, so I would say there's a lot of feedback in that mic. I would say for both for new and for new and for existing patients. Again, it's about understanding the person that you're in this relationship with. So you want to know how much time does my doctor have? And so I think if you really think that there's something important to you that will probably involve some length of discussion, then it's best to present that material ahead of the appointment so that they have time to read it. If it's something that your doctor has never seen before, or might only know just from hearing from a colleague or from some sort of news article or publication, then it gives enough time to have an opinion about it. And that way, when you come into your appointment, you're able to have a discussion. He's able to be educated on it, or he or she, I apologize. And so between the two of you, you're able to come up with a good plan. I think when in the setting of a very busy day, you're now presented with something that you thought it was a simple follow-up, and now maybe it's involves trying to learn something on the fly and answer questions, and maybe the patient's very nervous about something that's happened, and this information was very upsetting. So now you're trying to reassure the patient at the same time. There's just a lot to do. I'd say the more that you can set it up ahead of time, the better that will be.
It's really good advice. I never really thought about that, because you're always bringing everything with you and show it, but it makes a lot of sense if you can get information over, and most offices are now have those online systems where you can get in contact with your doctor, send stuff easily. So it makes a lot of sense to be able to do that. So now we're going to touch on a little more of the theoretical, controversial. So strap your bootlaces in a little bit. So not all pain is equal. And I don't mean that in terms of the experience of pain is, but when somebody comes in and says, I have pain, I can't imagine diagnosing pain is easy, because there's only so many tests that you can run. And unless there is, let's say, an anatomical defect to point directly towards what is wrong, it doesn't really give you a roadmap to how to diagnose the patient. So how do you go about distinguishing where pain is coming from, or understanding the type of pain somebody might be experiencing?
So trying to determine someone's source of pain, I think we try to break it up into certain pieces. So the more specific that a patient can be in answering some targeted questions, it actually does help to give us a sense of where the pain might be. So, for example, when did the pain start? What does the pain feel like? Is it burning? Is it aching? Is it feel like an electricity or tingly? All of those point you in a particular direction. Does it hurt all the time? Does it hurt if you make certain movements? What kind of movements? Is it at the morning? Is it in the nighttime? All of these things, they're like subtle clues that point you in the direction. And then that, in addition to a physical exam, we can do certain maneuvers to try to determine where the source of pain is. If we think it's in a place and we do a maneuver that's called a provocative maneuver, which is known to exacerbate pain in that circumstance, then that actually will give us some insight. I think that when it comes to these kinds of interactions, it's important for patients to, and I find that the questions are helpful, because often patients will say, "Oh, I didn't really think of it like that. Let me consider what what possibly might have when it started, or what maneuvers I was doing." I think that try not to come into an interaction and say, "I have pain everywhere," or "I have pain." That's more challenging. I find that to be difficult because how do you? It's like they say, "Oh, they have an electrical problem in their house," and it's like, "Well, where's the problem?" It's like it's everything. It's the whole house. Everything's flickering. It's like, well, I don't know what the electrician's really going to do if the entire house is going on and off. So you really just need to hone in a little bit better, and that would certainly help the doctor have a better sense of where it's coming from.
Yeah, and I remember there was one visit. Obviously, I give you full permission to speak freely about me. So, we're on this call. But I remember there was one visit I was particularly bad, and you were like, "Well, where does it hurt?" And I'm like, "Everything hurts right now." And you're like, "Marni, you gotta give me something to work with here. Can you pinpoint a little better where?" And you said, but you were very serious and you were really good about it. You said, "Do me a favor and just try to focus in on what is worse. What is the worst pain you're feeling right now, and where is it coming from?" And I honestly, when I walked into your office, I thought everywhere was hurting, because it was just the pain had gotten so extreme that it literally, it felt like I was feeling it everywhere. But when I concentrated down, I could feel where it was originating from and how it was coming, and just, it really was, it made me think. And now whenever I get like that, I stop, I breathe, I think about, where is my pain? Where is it originating from? What could be causing it? I do it. It's like a mental exercise I now do at home. Ever since it was one of our first visits that you did that, where we were pinpointing where to start on treatments. And it stayed with me to this day that no, my pain isn't everywhere. It might feel like it's everywhere, but for me, it doesn't happen to be everywhere. So that really stuck with me.
Oh, well,
The next sort of, I guess it is highly controversial topic I want to delve into is surrounding opioids. So there is the pendulum that swings, and we went from the 90s, where pain became the fifth vital sign, and it was tied, I believe it even became tied into hospital reimbursement, where if you checked that pain wasn't controlled, hospitals were denied, reimbursement. So it became, let's make sure nobody felt a single ounce of pain. And now the pendulum has swung back into suck it up, buttercup, basically, and I feel like there's, from the patient perspective, there's a lot of problems with that, because of course there are exceptions to, and I do believe there are times that opioids aren't appropriate, just like any medication in medicine. There are times you don't give out anticonvulsants when someone doesn't need them. You don't give out cholesterol medication to someone who doesn't need cholesterol medication, or so I feel like two things. One thing I also noticed this week is I don't know if you've seen it, there was a big ad campaign that went around about that was showing how it was conflating addiction and dependence, the physiologic action of your body becoming dependent on something versus, I guess, is it the psychologic side of addiction?
Mhm.
And I feel, where do you think, we'll get into your beliefs on opioids in general, but where do you think all this, I don't know if it's misinformation, miscommunication, or why do you think it's swinging, and what's happening, and the misinformation and everything that's floating around that's going on? Or if
Uh,
you want to start with your views on opioids and then swing into that, however you feel most comfortable to explain, the topic.
so I think that it's a challenging topic because people have very strong feelings about it typically. Well, like I guess it's almost like politics. People feel very strongly one way or the other. And for people who are actually experiencing pain, they often will feel very strongly that about their treatment and what's been working for them. So I think from I gue- I guess the easiest way to look at this is sort of build on our doctor and patient relationship perspective and to think about it from that light. So I can imagine that from a patient perspective who was being managed through that opioid time where prescribing was much more heavy, and so there was less fear. There was actually a time where doctors were told that opioids were not addictive, so they were giving them situations because there was no fears of addiction. So the the patients were started on treatment plans which involved opioids, and opioids do give you a great feeling of relief. There are people who have uh, pain that's above and beyond what opioids are able to do. But for a lot of people, they felt relatively well controlled, even if the doses were pretty high. The So everything's going well, and then the opioid pandemic happens, and now the opioids are not as readily available. So not only is the person who typically wrote you for your opioids no longer prescribing, but when you go see a pain management doctor, they're not prescribing, or they only prescribe a certain amount. So I completely understand the predicament. I don't want to say I completely understand because I'm not experiencing the pain, but I see the frustrations that patients would be experiencing, especially if they were on a stable dose and now are just struggling to find somebody. And so but I would say from the practitioner side, like you said, we were pushed to get pain scores down. It was all about Press Ganey scores. As the hospital needs all the patients to be happy, and patients who are poorly controlled pain are unhappy. If that's the case, then the hospitals get poor scores. So there was an impetus for us to prescribe more. And as things started to crack down, the now all of a sudden the DEA is telling us that you need to prescribe within a certain limit. If you're going above that, then you have to justify it. And so there's a lot more, the doctors are being busted for, inadequate or inappropriate prescribing habits, which they should be. But all of this creates like a buzz and a hype. Even recently I had someone who was prescribing, who doesn't typically prescribe medications, just to help one of his patients until he went to go see another provider. And it was the first time he was writing for not too high of a dose, at least in the pain world, but for him it was very high, and he was so afraid to write for it. This was a physician, feeling like he's like, well, I was waiting the next day for a phone call from the DEA to find out, if I did it wrong, if I need to be investigated. So I mean, there is a fear on our side as well, and I'm sure that will subside. We're kind of, pendulum was one way, now we're kind of the other way. I honestly think we've come back a little bit because now there's data showing that patients who were where that medication was withheld, in some instances fared more poorly because now they were going through withdrawal and they had other comorbidities such as, cardiac disease or something where when you're going through withdrawal, it's a big stressor and it can cause other problems. So where things are nowadays with doctors, I think, is that there still is that fear of prescribing opioids. The data is pretty convincing about if you prescribe an opioid, there is inherent risks applied to it. Marni and I discussed this before about, for all the other medications, say a cardiologist might write for, we're talking about heart disease, we want to lower high blood pressure, we want to lower cholesterol and all these other things. We're giving you a medication which we know will improve your overall outcome. It'll improve your health and improve your survival, where opioids have the opposite effect. They improve your pain, and you could argue they improve your quality of life, but in there's baked in other risks. So it's a hard thing to prescribe. Even I think now coming back into it, I think you'll see, my feeling is some slight uptick in prescribing, but it is a challenge for patients. I mean, for me, predominantly, I do a lot more procedural based pain management than I do medical management. And I think that from the patients that I've managed in the past, and I guess this is a lot of also where doctors feel like they are hesitant to do the heavier prescribing, is that patients who tend to be on a higher dose tend to become very passionate about that dose and that dose being effective. And so when the provider is saying, well, there's these risks, I'm concerned about this, it becomes a very heated, left versus right kind of argument that you really have a hard time, meeting a common ground, and it can be challenging. So, but I do believe there is a place for it. I'm not saying all opioids are bad. I'm an anesthesiologist. I get people through the hardest procedures or most painful times in their lives, and you have to prescribe, or you have to at least treat with an opioid to manage some of the swings. I probably use less, honestly, during anesthesia than I did in the past, knowing that I can actually use other medications that don't have to be opioids. But with that being said, you have severe pain, you will likely need an opioid. It will help your pain, especially in the short term.
Yeah, and I just want to also attest to, first of all, thank you for your candor on it. But when I was in the hospital, I mean, I've had so many procedures, I don't remember which one it was, but they were giving me an opioid, and I had to convince them I wanted IV Tylenol, because to me, I call that liquid gold, right? I think it was after something, and I was in the hospital, and you know what it was? I was getting so loopy, I couldn't get discharged because I couldn't stand up. And so I said, stop it, just give me the IV Tylenol. And they were looking at me like, what? Well, we have to get orders for that. And I'm like, I'm sure it's not going to be a problem. Go get orders for that. And people, I've seen it on the message boards, are outraged, that after surgery, they're giving IV Tylenol, they're not giving an opioid. And I was like, there's some credence to this, because I can speak firsthand that, like I said, my mother-in-law had big abdominal surgery, and she got, on the first day, she got opioid, but on the second, also with switching it with IV Tylenol. On the second day, she got IV Tylenol and was like, can I go home now? So I think I'm very much somebody who's in the middle. I think it's very important for patients to develop a care plan with their doctors, and to understand. I also think here's something that I was taught very early on, especially having this disease. And I credit my first pain doctor, who wasn't you, I'm sorry. But he once taught me about, with the pain medication, because I was terrified in the beginning of taking the opioids. And I had bought into that narrative of, if you lick it, you're going to be addicted to it, right? And I was petrified. But he told me, he said, listen, you have a disease of pain, and your symptom is pain. If you don't feel pain, you've cured yourself. You don't have a cure for your disease, so you should always feel some amount of pain, but it shouldn't be unbearable. So never take these to the point that you don't feel pain. Just take it enough so that it takes that edge off, so that you can function in daily life. And I thought that was fantastic advice. I really did. I was like, wow, as long as I just been taking enough to get the edge off so I can be a human being, it made me feel better that I wasn't, taking too much or going to do anything that would put me in jeopardy or that would harm me. And I really thought that was great advice, but that was years ago. So I really appreciate that advice. So
At it, I think if you're suffering from chronic pain, I mean, even from an interventional side, often we're looking at, I'm not going to take you from 9 out of 10 pain that you've had for, let's say, a year, and likely make it 0. You want to come up with a realistic goal that, to some extent, I mean, everybody has some level of pain. But if you can, whatever your treatment plan is, get yourself to a comfortable place where you have a good quality of life. And if you have medications that you take as what they call PRNs or as needed, you take them as needed. You don't try to suppress things. I have I don't know if we have time, but I can give you an anecdotal story.
Yeah, no, we still have tons of time. You're good.
So when I was a starting anesthesiologist, we had someone who, and this is when the pendulum was back over here, who was a typical patient who had a lot of, it was on someone who had sort of chronic, your classic chronic pain patient from back in the day, where they were on multiple continuous medications, multiple short-term medications, fentanyl lollipops, occasional patches. There was a lot of mixing going on. Very difficult to control. I'd managed this patient for a couple surgeries that they'd had for lung surgeries, as they were trying to just figure out what was going on, because this patient was having some lung issues and low oxygenation. They finally, I guess, got it right, did a lung surgery, took out a portion of the lung that looked like it was inflamed. They weren't sure if it was cancer, if it was, essentially what ended up happening was when they looked at the lung tissue, it was a piece of broccoli. She had taken so much to try to minimize her pain that she was basically aspirating, or when you eat food and it comes up and it goes into your lungs, full chunks of food. So that's probably a little too much. I would say you probably want to be more like Marni.
I think there's also somewhere in between that there's the Marni side, the broccoli side, and then probably somewhere else in between there. but that's it's tough. It's not an easy. I don't suspect that we'll come up with the answer to this that's plaguing. I think we need more open conversations. I think there's a lot of anger and a lot of on all sides. I think people are attacking doctors who are afraid and calling them, I don't say this, but like calling them cowards or saying it's your duty to take care of your patients. But I think we're forgetting that doctors are human beings. I think we're forgetting that you all have your views too. And if a doctor doesn't think prescribing is right in an instance, they're not going to, I wholeheartedly understand why they don't prescribe something. If they're doing it out of fear, or they don't want to go over a dose that they're comfortable with, I kind of understand that also. But at the same time, as I know our community is really in a tough spot, and especially our minority community, they're really, it's astounding the prejudices that happen. I get a little bit, being a woman. At the same time, it's not you. I know I could go into like the hospital that you're at if I was in extreme and having a problem, and I could tell them to contact you and it would be fine. But if I was ever away and I had to go to an ER for some reason, do I think I would be suspect? Possibly, being a woman, because sometimes they say it's hysteria and your disease is made up if they've never heard of it. But I can't even begin to imagine the experience of someone like with sickle cell, that they have to go through every single time they're go to the hospital, and the innate prejudices that they have to battle to get care and to get pain care. And it's just a topic that I think rare and pain really need to have more of a conversation surrounding, because there are certain instances that should not even be a question about, are they should these patients qualify for opioid pain medication, and therapy? And I'm still floored when I hear the stories from these patients that they're looked at as drug seekers because they go in and say, well, this worked for me, I know what it is. Just because you know what drug worked for you doesn't make you a drug seeker. And I feel like this is one of the biggest problems in pain, is that we get labeled. How do we counter that? I know I didn't prep you for this question or anything of that nature, but how do we work as a community to counter labeling?
I think that so in medicine, a lot of what we do is labels, unfortunately, and it's because it helps steer our diagnoses, right? So how do we manage someone? Okay, and when I say labels, I kind of, let's say a diagnosis. Let's say someone has this, and this. I know how to treat those things, right? So now Marni, we've talked about the word and how it has a lot of heat behind it, but the word of catastrophizing and
ding 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 ding. No, I'm just joking.
And the video's over. But I think that when I try to think about my interactions with people,
can you do me a favor before you go on? Can you define medically so my patient community understands medically what that term means?
Yeah, I would say so. When someone is catastrophizing, it's how they're interpreting or reacting to the stimulus of pain. So they're experiencing pain, and that experience to them is the worst thing in the entire world. It's debilitating, and not so much that they're saying that, doctor, right now I have a 10 out of 10 pain and it's really uncomfortable. I don't like it. So that is not so much catastrophizing. Catastrophizing is, there's almost a sort of like loss of control. It's just almost a frustration with providers where no one's taking me seriously. I feel like I'm gonna die. So that would be, if you were to try to define catastrophizing, it's, this is the end of the world. I can't go on like this. This kind of someone who's, let's just say, difficult to talk down. Someone who, I come to speak to someone who's in this state, or maybe not so much in that state, but just in general, when they are dealing with life, or dealing with pain, it's something that's extremely challenging, and that's kind of how I would define catastrophizing. In the medical space, when we see someone as catastrophizing, we would see that person as someone who is not going to be able to manage their pain very well, and is more likely to lean on opioid therapy, and maybe not necessarily appreciate the efforts of the staff around them more so than another person. So there's a lot in that. So
we could do it like a 2-hour presentation on breaking down the patient view on that word and why it's not a great word versus doctor view.
But what I would say is that, so as a provider, you need to be compassionate and yet protect yourself at the same time, and that's a hard balance to strike. I would say that when you have someone who's not able to emotionally handle or manage their particular pain, and everybody goes through cycles, but that's a hard relationship. I think anytime you're emotionally charged, whether it be because of something happening in your life, or let's just say pain, it's hard to speak about it in a logical manner, because you're not in that mind state. I would say that as an obstetrical anesthesiologist, I've seen patients before they went into labor who seemed like very very intelligent, very capable, very warm and compassionate people, who, when that labor pain hits, they look hysterical and very scary. And then, of course, as soon as the epidural hits and then the pain goes away, they're back to a very calm and appreciative person. So I can appreciate how being in that state makes it very challenging. But as a doctor, when you're going in to try to fix the situation, when you see catastrophizing, in some ways you put up a little bit of a barrier to protect yourself, because instead of diving headfirst into the situation to say, what can I do? All right, is it really truly something dangerous that we need to get extra scans? Like, are you going to lose your leg? Do you have an aneurysm that's about to rupture in your abdomen? You know, it's just, it protects you from, I guess, sort of emotionally diving into a situation that is more so a struggle that the patient's having at that moment than a true, you know, end of life, you know, this is the worst thing ever. So it's tough, you know, really. I would say, and this kind of ties back into the other conversation we had, how does a patient really sort of present themselves in a way and get the best care possible? I think that it's hard when you're in that pain state. I understand that. I think that, you know, I've managed sickle cell patients, and I've seen the easiest ones that I could work with. You can tell that they're in pain, but they have a realistic, or at least in their own mind, a realistic expectation as to what, especially they've been through it multiple times, that I'm going to come in for a couple of days. I typically go on this dose on my pain pump. This is usually enough to get me through. I don't expect to go on more than that. If anything, I'm going to be the one to tell you that I want to go down on my dose because I want to get out of here and go back home. That's someone who practitioners love to take care of, because it takes away that constant daily battle of up and down, up and down, up and down on the doses of opioids. I think it's hard when you meet someone for the first time, and let's say you come into the emergency room and you're in severe pain. The challenge is, how do you not look hysterical? How do you try to calmly express that I have horrible pain, it's coming from here, it started on this time, it feels like this, and you know, I just need some help. That's.
But at the same time, and I don't mean to interrupt you, when I've been misjudged because I've been calm, you know, you can't possibly be in as much pain as you say you are because you're so calm about it. No, I've learned how to swallow and deal with it, but because I'm not throwing myself on the floor screaming. So it's almost like you're darned if you do, you're darned if you don't.
You're probably right about that. I would say that, but I would say that from the provider standpoint, it's like, I will gladly speak to you for 30 minutes about, you know, about your pain, even if and maybe dive in a little bit deeper and try to figure out where that's coming from, than someone who's I can't really communicate with, because the pain has gotten, you know, pain is everywhere. So it's just easier for that dialogue to happen. And I'm more likely to come back check on you later, because I will believe that you're giving me a story and you're doing your best to really present the information, you know, as best as you can. And, you know, I think that that's probably a good representation for what the providers are experiencing in the hospital and their interactions with patients, especially patients who are having a lot of pain. You know, the other side of it too is we've been burned by patients as well. I'm sorry, go ahead.
No. I was just gonna say, and I agree, and I understand your assessment, because I think anybody who's hysterical, you can't have a conversation, you can't communicate with. But I think you can at least understand, especially in rare or in some of these pain conditions, when you have been ignored and dismissed, why we might get to that level. So my advice from the patient, because you're very logical, but I guess my advice from the patient is it's okay to express your frustration and that you've been dismissed, and patients want to know that they're not, you know, have that acknowledged, that you know, from the doctor, that we understand that this has happened. But I think it's important for us patients to also keep a level head. I think there has to be a balance between the two. Like you said, the patient that walks in with that folder, you know, wants to be seen and heard. It's the same thing with that a hysterical patient at the same time. Is if somebody looks at us and says, okay, we know we're going to help you try to figure out what's wrong, but I need you to calm down. I think instead of maybe putting up that wall or writing us off, or I think it might go a longer way. Of course, I'm not there in the ER and I don't know what's going on, but I think a lot of us are just at the end of our ropes, when the pain is that excruciating and nobody can help us. And some of us genuinely do think we're dying. In the beginning, when we didn't know it was CRPS, I thought I was dying. I thought something was wrong and we didn't know what it was. And I didn't know how something could live in that much pain without the body dying. I mean, I now know you can exist in that much pain and not be dying. But I was really scared that we were missing something incredibly vital, and I was bleeding out internally, or who knows what. So I can empathize with those patients.
Interesting. That feedback.
No, go ahead.
I was gonna say, so it's interesting that you say that, because as I said, I'm trying to determine, is this the life-ending devastating injury? That's is this something really traumatic? Is there something that I'm missing, some infection somewhere? And you're feeling the same thing. So if we both go down this pathway, we could be doing CAT scans, MRIs, the whole thing, and maybe it is not that severe. So it's hard to strike that balance. But like you said, I think to the best of your ability, if you can keep a level head, but I understand that that's hard to do sometimes.
Yeah.
I think that does this segue into our next conversation?
No, go ahead, whatever you want to.
We were talking about, I think, when we talked about catastrophizing, managing pain. I always think that it's important to understand what pain is, right? So pain itself is experienced differently by everybody, right? So the definition of pain is some sort of stimulus, some unpleasant stimulus that actually produces an emotional response to it. So, I mean, if you give someone ketamine, for example, which is something used quite often in chronic pain states, it produces a dissociative state. So you can take someone who was, and what that means is you take someone who's before ketamine saying, ow, this hurts me, and I can't take it anymore, please stop, I need some medication, or, how am I supposed to sleep with this level of pain, something like that. And then you give ketamine, and then you repeat the question, you say, are you in pain? No. Or yes, but does it bother you? No. Do you feel what's happening? Yes. Are you upset by that? No. So you can, the better that as human beings, we can kind of modulate our emotional responses to things, the better you are, or better we are at controlling our response to that uncomfortable stimulus. So I often recommend to patients to go and see either a psychologist or a psychiatrist, or just to have someone help be that person to give them some of the necessarily tools to better cope with even some of just life stressors. So I'm a big believer in therapy. Even as a provider, I have to make sure that, to the best that I can, not impart my own biases into my interactions with patients. And we all have biases. So I would say that it's beneficial for multiple things, but especially in pain management. I think that you need the tools, and often, and this isn't all the time, but there are patients who have underlying anxieties and depressive states will very likely end up in chronic pain states. There was actually some good studies regarding patients undergoing total knee replacements, and the ones who had pre-existing anxiety and depression were more likely to develop chronic pain after their total knee replacement than patients who did not have that. So providing those tools and those coping skills even beforehand, I think is certainly beneficial.
Yeah, I'm a huge believer in mental health and mental health support, and whether it's seeing a social worker, a psychologist, a psychiatrist. I think it's vital to the pain experience, because it's a dark road. Because you know, there are times it's controlled, there are times it's uncontrolled. It absolutely changes your life, and you have to learn how to manage it. But one last topic I really want to touch on, because it absolutely fascinated me, and that is pediatric pain management. We were talking about it briefly, but how is the management of pediatric pain different than adult? If you can touch on that.
So I would say pediatric is one of those things where it's not just, you're not just focusing on a patient, because now you're focusing on the parents or whatever caregivers might be involved. So it's a little bit more complex, because you need to get everybody on board to help, especially when you have children who may not be able to best communicate what they're experiencing. You may lean a little bit on some of the caregivers and ask them, how is he or she acting? Is this normal for them? Do you think that they're in pain? There are specific pain scales that you can use, which are targeted towards children. So that's always a useful tool. I would say that so in the pain management space, there's both, there's the medical management, and then there's the interventional management. If you're looking at someone, there's just less options, I would say. Not so much that pediatric patients can't undergo specialized interventional pain procedures. It's just that there's less people who are specifically trained to do that, or sort of in that space. So if someone has a child who they feel is just really having a hard time managing some chronic pain state, and it's probably in their best interest to look more towards academic centers, because those would be likely the ones to have someone who has spent the amount of time and gotten that specialized training in pediatric pain. So I know one person in particular who was a pediatrician, then pediatric ICU trained, and then anesthesia trained, and then interventional pain management trained. So I mean, that's someone who's going to know pediatric pain through and through, much more so than me. And I think the best thing you can do is, if you're really struggling and don't really know who to turn to, even just contacting the anesthesia or pain management department of your local academic facility, and just ask them who would they recommend. And even if they don't have someone there might be someone at an adjacent facility. And that's probably at least how you get started on that pathway. If you feel like you're not not being managed as well as you would like to be, then just start doing a little bit of searching. And there are people out there, and they're, if they're going to spend that amount of time to do the extra training to take care of a child, I'm sure they're going to do a good job.
And if you don't mind speaking about it, what I found so interesting was you were telling me about that local study that had done of using virtual reality and pediatric pain.
Yeah,
you don't mind talking about that a little bit?
Of course. This kind of lends itself to that discussion we had before about how you interpret pain. And so when children experience a second, third degree burn, and they're hospitalized in the ICU, and they have frequent burn dressing changes, the dressing changes are incredibly painful, probably one of the most painful things that you could experience. And so you can imagine as a child having to undergo anesthesia every single time you're getting a burn dressing change, and you're concerned about the child's well-being, and I'm sure as the parents, they're really nervous about it. So they had done some studies looking at like an immersive virtual reality in children. So they wear a headset, and the headset, you can move your head around, and you're in this 3D space. And the effect of that is it's like shining a high-powered light on your brain, and so it's really difficult to focus on other things. So pretty significant reductions in acute pain during these dressing changes. So there are modalities out there to help kids in the hospital with pain, and it's like I said, these things are probably best found in academic centers.
Great. And with that, I believe we have hit our time limit. I just want to really thank you for taking the time to come on here and discuss so openly some topics, which I'm sure are not the most comfortable, but we really appreciate it, because anything that we can do to facilitate building a relationship between patients and physicians. And I think what the key word that we learned today is that it's about communication, being open and honest between, as a patient, be honest with your doctor. And I think one of the things which we didn't unfortunately get a chance to talk about is I think it's important for our physicians to be willing to sit down and explain themselves to patients as well. And I think sometimes it's a little bit lacking. I don't have that problem with you, but sometimes, treatment courses get told to us, or recommendations are made without explanations behind them. And for any physicians that are watching, because I know this is medical day, if you're wondering why we might not be receptive to your ideas, sometimes it just takes a little explanation and we don't understand why you're suggesting what you are. So if you just take a little extra time and explain it to us, sometimes it makes more sense and we become much more agreeable to it, or it's not the right course of treatment for us, and you have to respect that as well, which we've also talked about when things are not the right thing. And it shouldn't sour the relationship. I think we both can agree to that just because we don't necessarily agree on a treatment plan, direction, it doesn't mean that our relationship as doctor-patient is over.
Yeah.
Anything, words of wisdom you want to leave the people with?
Yeah, I think that it's part of that interaction. I think that doctors have to remember when they have with patients is to set expectations, and also, you all come, both the provider and the patient come in with certain expectations about what this interaction is going to be. And I think that at some point during that interaction, you should at least make sure you're both on the same page and say, what do you expect to get out of this? What is quality pain control to you? So I think that's important, because you want to set the tone from the beginning.
Great. I think that's wonderful advice. And with that, we will sign off. Thank you so much for joining us, and enjoy the rest of the day.
Thank you, Marni.
Take care.